that shows the irregular lobulated lesion, a lobulated lesion of size
Let's
5.2 centimeter with
make it brief. So there is a lesion in the right upper lobe abutting the major
right upper
fissure.
lobe of, yes, sir,
Anything
abutting
else?
the major fissure. Sir, also there was a lymph node in the left, down please.
Left what?
So left mediastinum, like left para-aortic lymph nodes, like ipsilateral lymph nodes were involved and the left para-aortic lymph node.
Okay. Okay. There was a single met in the adrenal. So it's a metastatic disease.
Yes,
Okay.
sir.
Right. Next.
So the patient underwent the CT guided biopsy from the lung that shows infiltrating
Next.
adenocarcinoma, moderately differentiated. Patient underwent biopsy was taken and was confirmed. So
So the biopsy was done through EBUS and not CT guided.
outside they have done, and the report was not available. So that's why we have done the EBUS.
Okay. Because you don't require an EBUS once you have a diagnosis from
Yes.
CT guided. Only if you need to stage the mediastinum, we need to go for an EBUS.
Yes, sir.
Okay. Next.
So
what are the investigations
sorry,
you
sir.
send on the pathology report?
Please repeat the question,
What are
sir.
the investigations you will send on the pathology report? What further investigations will you send on the pathology report?
I would like to go ahead with CK7 first.
Tell all the markers.
So for adenocarcinoma, it is CK7, TTF1, napsin, and for small cell lung carcinoma, it is CD56, CK8, and the chromoplanin
You will not do small cell once you get a diagnosis of adenocarcinoma. Only thing is to differentiate with squamous.
So squamous is P40 and P63.
Correct. Next investigation.
Sir, if out of all these markers, if sir, it shows that TTF1 is positive, so it is adenocarcinoma.
We are going to make it as adenocarcinoma. Let's go with adenocarcinoma. Next
investigation, the metastatic disease, and in the staging workup, that MRI brain is also included, but that is a metastatic setting, so we will not. So I will not go ahead with the MRI brain.
What does NCCN say?
So MRI.
Okay. So, but it's okay. Your answer is accepted. If it is institution indicated.
In ideal setting, you need to do MRI brain.
Institution protocol is fine. No problem. Do you want
is
to go
asymptomatic? No.
Biopsy. IHC over adenocarcinoma.
Sir, I would like to send for the moleculars.
What do you want to send?
Sir, I would like to send for EGFR, ALK, ROS, RET, MET, ROS1, and ERBB2, and PDL1 as well, P53, and BRAF.
So you need the broad panel.
So I would like to send in 12 gene panels with next
Okay. Patient doesn't have any money. You have to choose.
Sir, then I would like to send EGFR, ALK, and I will send for KRAS and RET.
Okay. What is the basis of your choice?
Sir, history of smoking is there. So,
no, that is not the basis. The basis should be based either on a guideline like NCCN or a pathology guideline like CAP ISLC guideline. Do you know the CAP ISLC guideline? Updated was in 2018. So in that, they have mentioned we have to send EGFR, ALK, and ROS1. Only these three. And NCCN also includes RET and I think RET PDL1 also
PDL1, yes.
as category 1 because things have changed after that. And when you're sending a broad panel, you are welcome to send whatever you want. BRAF, RET, HER2, exon amplification MET, exon skipping
exon
MET,
protein
all
skipping
those.
mutation.
Okay, so you send
BRAF.
all that. You send the broadband. No mutations. PDL1, 2%.
So I would like to go ahead with the systemic. Would like to go ahead with the
Okay,
systemic
tell me.
therapy, sir.
What?
So I would like to go ahead with Pemtrex and carboplatin.
Only pemetrexed carboplatin. So do you know how?
Sir was mentioned the PDL1 percentage is 2%, and patient is not having an actionable driver mutation. How do you plan your treatment?
So if I'm not wrong, then atezolizumab and Pemtrex and carboplatin.
Okay.
Patient.
IM? Empower?
I am power 130. Empower 130.
130. Okay.
I suggest you to not to mention the name of any immunotherapy. We can say there are various immunotherapies approved in this scenario.
Idea. Okay, for medical setting in your hospital.
Sir, we go ahead with after the moleculars and PDL1, and if it is there, so
yeah, I already told you that. Tell me the drugs you are going to use.
So Pemtrex and carboplatin will go ahead with like 5. And
I mean, I'm asking what you use as immunotherapy over there. Is it Atezo or Pembro?
So pembrolizumab.
Then why are you saying Atezo? I know it's pembrolizumab you'll give. So just for the information of the students, how it's divided is very simple. If it is between 1 to 50%, we will give pemetrexed, carboplatin, pembrolizumab. Above 50%, you have an option of giving pemetrexed, pembrolizumab alone. Correct?
Yeah.
This is the standard treatment.
Yes,
Now, why carbo? Why can't you use cisplatin? It doesn't make a difference. Pemetrexed,
so voice is
carboplatin.
breaking, sir. Can you repeat
Why
the
did
question?
you carboplatin?
Yes, sir.
Pemetrexed, carboplatin. Why did you choose carboplatin instead of cisplatin? The initial trials were pemetrexed, cisplatin. Have we lost you? Hello?
Sir, but your screen is blocked and voice is also not. Now you're okay, sir.
Yeah. Yes. So my question was, why did you choose carboplatin instead of cisplatin for this patient?
Sir, because cisplatin is nephrotoxic. The toxicity profile of cisplatin
He doesn't
is
have any
more
kidney
than carbo.
problems. BP is well controlled. 130/80.
Yes, sir.
Does it make a difference? Yes,
I am
no,
aware
no,
that.
no. Okay.
Sir, toxicity profile of cisplatin is.
Does it make a difference in outcome? Yes. No, don't know.
Don't know, sir.
Okay, so it doesn't. Okay, so there was a trial that compared pemetrexed cisplatin. They found was that there was a slightly better overall response rate, but the 1-year survival rate and PFS was equal. So you can substitute. Everybody else, please.
Dr. Himan,
Yes, sir.
actually, you mentioned the pemetrexed.
Sir, just 1 second. Just 1 second. I would, Niyati, can you kindly mute your. Yeah. And Dr. Gokula Krishnan, if you can also kindly mute.
Thank you. Jyotish, go ahead.
Sanita, write down the prescription for this pemetrexed and carboplatin with pembrolizumab. And how do you administer?
Pemtrex. milligram per meter square AUC 5, sir.
No. He asked you to write the prescription. Tell the prescription, the complete prescription.
Sir, injection Pemtrex 500 milligram per meter square in 250 ml of NS, IV over 3 hours, and injection.
IV over
3 hours.
3.
Pemetrexed is given over.
Okay. Read the package insert.
Yes,
It's
sir.
10 minutes. 10 to 15 minutes is enough for Pemetrexed.
Yeah. And what are the prerequisites before
And,
starting Pemetrexed?
Yes, prerequisites.
It's a vitamin B12 levels we need to check.
How much?
And,
When?
Sir, not right.
Yes, no, don't know. Simple. We are here to learn.
Don't know, sir.
1 mg IM or IV 7 days before start of Pemetrexed. Next.
Can be repeated every 3 cycles.
Every 3 cycles, yes, sir.
And folic acid, it is 500 to 1000 micrograms.
Let us say, do you know?
Initially 7 days prior to the Pemetrexed and have to continue.
Yeah. That's a daily dose.
Okay, sir. Daily dose.
Yeah.
Okay. Carboplatin.
So we calculate with the Calvert's formula, and in 500 ml of D5 IP over
Do you know
3
Calvert's
to 4
formula?
hours, sir. So Calvert's formula, we calculate the GFR, sir, and plus 25 and into the AUC 5, AUC, so if it is 2 or 5, so we multiply with that.
How will you give it?
Mentioned it is administered over?
So 3 hours.
3 hours.
3 hours.
Okay, this is for all the students here. Okay, I was just having a discussion with Jyotis. Basically, you guys are all good at your job. You're going to read well. You're final years. You will be, I mean, you can tell the trial, Empower 130. You can tell the trial findings. We know all that. And the examiners also know that. So they will catch you on these, the simple things. So I think, I don't know how it is now, but before any chemotherapy that you give, you should have given personally. We used to go and mix the chemotherapy and administer. And we have to read the package inserts. We should know how much in what, carboplatin in what, NS or 5%, and over how much duration. This is very important. They will catch you on this because they know you don't know. You've studied all the big stuff, you forget the small ones. So please keep that in mind. Carboplatin is given over 30 to 60 minutes. It can be given either in 5% dextrose or in NS. Any other chemotherapy that's given in 5% dextrose? That will be the next question.
Somebody has mentioned in the chat box.
Don't look at the chat box. Imani, don't look. Baki, everybody can look. Come on, it's easy. Tell one. That chemotherapy cannot be given in anything else. It can be given only in 5%.
Sir, liposomal.
Amphotericin B, yes, but it's not chemotherapy. Oxaliplatin.
Oxaliplatin.
Yeah. Oxaliplatin, Araci, mitomycin. These are the drugs that can be given in 5% dextrose. Okay, next. So carboplatin, you want to comment on how you give pembrolizumab?
So pembrolizumab, so 200 milligram and dilution, so
in
500 ml of NS.
NS.
IV over 2 hours.
2 hours. Okay.
Over?
It's actually 30 to 60 minutes. Okay. So this is something that they will catch you on. So this is something that you have to read before you go. Right. So you started on pemcarbo, pemetrexed, pemcarbo, pembrolizumab. When are you going to reassess?
So after the 4 to 6 cycles of chemoimmunotherapy, we can reassess, sir.
Okay, reassessed 4 to 6. It's usually 3 to 4. Trials actually is 3.
Cycles.
In Amrita, I know for a fact it's done in 4 cycles.
4 cycles, sir.
So after that, after 6 cycles, you will reassess again. Do you want to do a PET scan?
I'll go ahead with the PET scan, sir.
Why?
So
What
because
more
it's a metastatic disease, and there was a oligomet, sir, in the adrenal, and I would like to see the status on that, and I would like to see if it is.
You can see it in a CT scan. Why do you want PET scan?
So for the comparison would be better, because previously on the baseline the PET was done, so it is
How is the
easy to
comparison
compare.
better? So the answer is, when you're giving immunotherapy, you have to do PET scan, because metabolic response may be entirely different from anatomical response. Okay,
Yes,
that's the answer.
metabolic response. Yes.
Okay, so there's also the issue of pseudoprogression and all those things, right? So okay, so 6 cycles over, what are you going to do? Partial response.
So it's a partial. So maintenance pemetrexed, sir, will continue, sir.
Only pemetrexed.
Along with the pembrolizumab.
Okay, so you continued pemetrexed and pembrolizumab. After 6 months, patient comes with headache and increase in cough. How will you reevaluate?
Sir, I'd like to go ahead with the whole body PET-CT along with the MRI brain.
Right. So showing progressive disease, new liver lesion, and a single brain lesion.
So if there is a single brain lesion, then if it is amenable to surgery, then
Surgery? Why do you want to do surgery for this?
No, sir. If the patient is asymptomatic,
He is symptomatic. He has headache.
but yeah, he is symptomatic, you can go ahead with the whole body, whole brain RT, sir.
Whole brain RT. Why? Why do you want to do whole brain RT? It's a single lesion. So next question you should ask me is?
Location of the lesion, sir.
Size. Location, more location, size matters. So there is a cutoff for what RT? What type of RT are you going to offer him? Something other than whole brain RT. What does whole brain RT cause? Okay, that's something you have to read up. Okay, whole brain RT has a lot of side effects. It can cause, in the immediate stage, it can cause confusion. In long term, it can cause memory loss, change in habits, a lot of things. If there's a single lesion less than 5 centimeter, I believe 5 centimeter is the cutoff, I'm not sure, you should offer stereotactic brain
radiation surgery.
Okay. So that you save a lot of the normal brain tissue. So that's the answer. You have to give SBRT. Okay, SBRT given. Next step.
So if
you are giving SBRT in a hurry because he is symptomatic. If he was not symptomatic, the next step would be next step. He has progressed on Pembro.
Then I would like to go ahead with the second line of chemotherapy, sir.
You don't want a repeat biopsy?
Repeat biopsy would be required, sir.
Yes. Where will you take it from?
So I would like, if the lesion is a peripheral lesion, you said that there's a lung lesion, new lesion. If it is a peripheral lesion, so
new liver lesion, old lung lesion is increased.
So liver lesion.
Yeah, whichever is easily accessible.
Easily accessible. If there is a liver lesion that is accessible, I'll go ahead with the
patient is not keen on repeat biopsy. Do you want to do a liquid biopsy?
Liquid biopsy, yes. We can go ahead.
Yes. You're sure liquid biopsy is fine. Okay, so liquid
So,
biopsy
but
has
liquid biopsy we mostly do
specificity to
with the
compare.
patient with the germline mutation, sir.
What? Standard liquid biopsy for lung, what does germline have to do with it? And anyway, EGFR is not going to occur in germline, right?
Sorry.
So liquid biopsy, why are you doing? In other words, again, what is the CAP IASLC guidelines 2018 for liquid biopsy? Guidelines, write it down, go read.
Okay, sir.
CAP IASLC 2018 guidelines. You search it, you'll get. Liquid biopsy is not recommended if you can get a tissue biopsy. If the tissue biopsy fails, you can take a liquid biopsy. Or if the patient is not willing at all, and you have no
Then we
choice,
can
you
go
can
ahead.
go for a liquid biopsy. In this case, let's say the patient went for a biopsy. Okay, and
Yes.
get that the new PDL1 is 0, and you have a KRAS mutation.
Sir, the PDL1 it is 0, so immunotherapy we have to stop by, and KRAS is
That
there,
doesn't mean
so
it's
we'll
suffering
go
because
ahead with the second line. Go ahead with the.
second,
Garas mentioned there is a KRAS mutation. Do you want to ask something more?
let me ask you another question. What is the most common mutation in adenocarcinoma? Lung.
Sir, KRAS mutation.
No,
Um,
it's actually P53.
So TP53 followed by
Second
EGFR,
is,
then KRAS. Thirdly.
again, not exactly correct. In Western population, it is P53, KRAS, EGFR. In our population, it is P53, EGFR, and KRAS. EGFR
Then
is up to 40
KRAS.
to 50%. There was a study from Amrita itself with the percentages of EGFR. I think it was 36% or 35% or something.
35, yes, sir.
To add on to Shoksa discussions, what is unique in lung cancer in Indian patients? There is a paper in Lancet. Normally, how many percentage of lung cancer is associated with smoking?
Sir, 80%.
Yeah, 80%. But in Indian patients, in that paper, it is around 40% are never smokers. Okay,
60%.
and usually occurring 1 decade earlier. That is one thing. Another thing is regarding air pollution, especially the particulate matter is about 2.5.
Yes,
There is
sir.
an association is there. Okay. And previously we had a discussion of tuberculosis and lung cancers. So do you want to add anything on that? Tuberculosis and lung cancer? Can tuberculosis cause lung cancer?
So tuberculosis can cause lung cancer because there is a chronic inflammation there is there and fibrosis is there that can predispose the patient for lung cancer.
Okay.
Any chronic lung disease can lead to lung cancer later on. Just want to answer something in the chat. Single brain metastectomy is an option. It will depend on site. Yeah, if it is difficult to operate site, we're going to go for a RT, and obviously RT is more preferred in patients with a PS2 performance status to start with. So okay, so Dr. Jyothi asked something. KRAS, you want some more information? And you're going to start on chemotherapy. What chemotherapy?
I would like second line chemotherapy would include docetaxel and
Vaccine. Okay. And
so the options could be docetaxel, gemcitabine, and could be
single agent or double agent?
nab-paclitaxel. Sorry, sir.
Single agent or double agent?
Single agent.
Why can't you continue carboplatin? He's got nearly a year of survival.
You can continue, sir.
Okay. You gave that for around 3 months. Next evaluation, patient has progressed again. Brain is stable, systemic progression. Next line.
Then we can consider, sir, not sure, sir.
Okay, so here comes the answer to what Dr. Jyotis asked. What do you want to know in the KRAS mutation? What are the most common mutations in EGFR?
Sir, exon 19 deletion and L858R mutations.
Where is L858R situated?
Sir, exon 21.
Okay. What is this L858 and R?
Sir, these are the L and R. These are the residues on which the
It's what?
translocation. So these are the location of the mutation.
Yes. Location is 858. L and R are
The residues, sir.
residue.
That
Oligonucleotide.
that amino acids, sir.
Yes.
That lysine and
You don't have
arginine.
to say the names. That's okay. So basically, one amino acid has been replaced by another one.
Yes.
Correct? Right? So that is
Yes,
the
sir.
identifying feature of that mutation. So the most common mutation in EGFR is where one amino acid is replaced in the 858 position by another amino acid. Correct?
Yes, sir.
Do you want to know anything like this for KRAS? That is the question.
So the mutation that G.
It's in the chat. It's like somebody's message like 4-5 times. Okay, it's G12C. Why G12C?
G12C. So targetable that targetable drugs are available for that.
Which one?
Sotorasib, sir.
Is it available in India? I'm not sure if it's available in India right now. I'm not sure. Jyotis is available?
Only sotorasib? No, sir, it's not.
Okay. So I have given for
We
two
have two
patients.
drugs, sotorasib and adagrasib. As per
Yes,
this.
adagrasib was another one. The reason why adagrasib and sotorasib is very important in oncology is because KRAS was considered an undruggable target. It was almost impossible to find a target for it. And after many, many years of research, they were able to finalize and bring out sotorasib. And the effect was moderate, very modest. So when you have a KRAS mutation, first question you ask is it G12C? And it works only for G12C. Sotorasib will work only for G12C. You will see G12D, G12E, it will not work. If it is there, you have an option of putting it in the second line or going for chemotherapy. In my personal opinion, all targeted therapy and probably all immunotherapy work better the earlier lines you give it in. So my difference in this case would be to offer sotorasib in the second line because we can always give chemotherapy. So I would go for sotorasib first. And if that progresses, we can go for the next second line chemotherapy or the third line of treatment, which is the second line of chemotherapy. And that you can choose whatever you want. You can choose, gemcitabine, taxanes, paclitaxels, nab-paclitaxel, anything you want, irinotecan, vinorelbine. So many options are there. Right. Okay. You said that you will be testing all this mutation panel and you will be doing PDL1, correct?
Yes, sir.
Right. So suppose the patient was affordable. Again, mutational status was negative. PDL1 is 0.
What's the
Okay.
mutational status, you said?
Mutations all negative. PDL1 is 0.
Yeah.
So obviously you wouldn't offer pembrolizumab, right? And
So the benefit.
Yeah.
So we can offer, but yes, the benefit with more than 1%, more than
That we
50% is
know.
much better.
No, you cannot simply offer like that. There should be a good reason. Otherwise, that person will come back and sue you after some time. You should have, please, all of you, please follow the guidelines. You can have the best interests of the patients at heart. but you have to save your own ass first. Nobody will save it for you. Okay. PD-L1 0, I would highly recommend against giving immunotherapy unless you do one more test.
Tumor mutational burden.
Right. What's the cutoff for tumor mutation burden to initiate immunotherapy?
Sir, it is 10, 10 base, 10
10 what?
megabase pairs. 10 megabase pairs.
No. 10 mutations per
10
megabase.
mutations per megabase pair.
More than 10 mutation per megabase, yes, you can offer immunotherapy and he cannot sue you. Even if he sues, he'll lose. Okay, so that's that. Let's take another scenario. Patient was EGFR positive. Now, this is actually a patient that came recently to me. EGFR positive was a lady, given Geftinib, progressed in 9 months, started on osimertinib, progressed in 4 months. T790M is negative. Started on chemotherapy. Which chemotherapy would you offer? Now you can tell the trial also.
So that atezolizumab with the chemotherapy that Empower
Empower?
130.
No, it's 150.
That no, sir. Empower 150 trial in which we give the ABCP, sir. Atezolizumab,
Correct. Why?
bevacizumab, and carboplatin. So because this is the only trial in which gave the chemoimmunotherapy with the patient with the EGFR mutation, sir. So and the
Every
overall
trial
survival
there has been
and progression-free.
no, that
Yes,
is
sir.
there. See, every trial there has been, even with Pembro, Atezo, Durva, everything there has been EGFR also tested, but no other combination has found to have any clinical benefit in EGFR positive,
Clinical benefits,
except
sir.
ABCP, which is why ABCP is given. Yeah, somebody had mentioned Mariposa also. Mariposa is another option. Mariposa 2, that was presented in ASCO 2024. Right. So we've got 5 minutes. So it's a 1 hour thing, no? So we've got 5 minutes. Jyotish, you want to answer something?
Yeah, I will ask something. Regarding this PD-L1 assays, what is the combined proportion score?
So combined proportional score in which we in which the tumor that are expressing the PD-L1 along with the other immune cells that are expressing divided by the number of the cells. So for example, if 100 cells are there, that out of that 50 are expressing PD-L1 and immune cells are 10, so it is 50 plus 10 over 100.
Okay, fine. What is which one is
so tumor proportional
CPS
score
or
in
TPS?
this sir, TPS.
TPS. Okay. What is the difference with CPS? There is no immune cells in tumor proportion.
Sir, in that
score.
immune cells
Only
are
tumor,
not counted in the
tumor cell staining is taken.
staining is required, sir.
Your patient is your patient is a 68-year-old, right? Do you want to
Yes.
do some geriatric risk assessment for this patient? Yeah. What are the scores available?
Can I ask something on this CPS TPS?
Yeah.
What is TAP?
What is it?
TAP. Heard of it?
No, sir.
If anyone's heard of it, they can put it in the chat. It's not tumor area positivity, it's tumor area. Tumor area, tumor area positivity, correct. So basically, it's a new terminology. It came out in the Matterhorn trial. Matterhorn trial was a preoperative, it's not related to CLN, just a point of interest. It was the only immunotherapy trial to show any benefit in gastric cancer, perioperative setting. And that was Matterhorn, addition to durvalumab. And in that, the big difference is they did not use TPS or CPS. They used an entirely new thing called TAP, tumor area positivity.
Okay.
And only above a certain percentage, they saw that there was a benefit for adding durvalumab. The others actually, it was statistically, numerically, it was actually durvalumab arm did worse than the chemo only arm of FLOT plus durvalumab. So just a new thing that came out. You have to uh, new drugs we'll keep hearing. These things you have to really read the trials. Then only you will get to know all these small things. Like when HER2 low, HER2 ultra low came, an entirely new segment came out. We had never studied this. It was not there in 2015, 2016. So we had to relearn what is HER2 ultra low and all those things. So read the trials if they are interesting trials, and especially because Matterhorn, it was a shock because it was the first trial to show any benefit with adding immunotherapy. So these sort of things have to. Can we give osimertinib for T790M mutation negative metastatic lung cancer? Yes. Osimertinib is an approved second line EGFR TKI. So if it is an EGF, see, I think Dr. Nirmal, what you're asking, if say the patient has a L858R, you gave is there any situation in which you will give afatinib first line?
Lux trial was there in which they have compared afatinib with the chemotherapy.
Yeah, but now osimertinib is far superior.
Yes, sir.
So is there any situation in which you will at least think about giving afatinib
So
first
I'm
line?
not sure, but if the patient progresses,
No, first line. So
Demand
basically the answer is
mutations.
rare
Yeah.
mutations. Rare mutations. So if you know the percentage, L858R and deletion 19 constitute 90% of the mutation. One is 40 and one is 50%. The rest 10%, again, there are small mutations, there's a lot of types of mutations that nobody can remember. You also don't need to. Afatinib will work. Just we are at
Mainly the G719X and I think
yeah,
L861Q. Those are all afatinib sensitive mutations.
Jyotish is more fresh than me, so he remembers all this. I have no clue what these things are. Dr. Udiptya, shall we wrap up?
Sure.
Any other questions?
So any
Yeah, so take on message, guys, please go read CAP guidelines. Some things that they do ask. I hated studying stage, breast, lung, ovary. There's no escape. You have to learn it. So, but where you will be caught is the simple things like writing a prescription or telling what is the mutation, the exact mutation. The trial and all, everybody will know. And they won't ask you, they know you know. Sotorasib, adagrasib is in second line, yes. Yeah, Dr. Udiptya.
Thank you, Ashok sir and Jyoti sir, for the excellent
thank you, sir.
examination. And as sir mentioned, like I'll just take 20 seconds because I just finished my exam in April. So you have to understand that as sir was need to know each and every detail of a prescription. You have to start with telling the pre-medications. If it's pemetrexed, you have to start with vitamin B12. You have to start with folic acid. When do you practically start? Not the textbook one. Generally, we don't end up giving with vitamin B12 1 week before. So that is one. And then secondly, obviously, you need to know the administration, each and every detail of how much ml you mix and how many minutes do you give it, and why carbo, why not cis, what is the excretion of carboplatin, why is it AUC and not the regular BSA. So these are the very important points that you have to know more than anything else. So thank you, everyone. Thank you, Ampok, for giving me the opportunity and giving us the opportunity to learn. We are all learning every day. So thank you so much.
Thank
Thank you,
you.
sir.
All the best, Mani.
Thank you, sir.
Take care.
Thank you. All the best.
Thank you.
All the best. Yes. Thank you.